Right, you must have read a recent report by the World Poverty Clock, which estimates that Nigeria is home to the largest extreme poverty population in the world, of course, with more than 50% of the estimated 180 or so million population living in extreme poverty. You must have also heard that over the years, that's the next 30 years, Nigeria will experience another boom, not what you think, that by the year 2050, Nigeria will become the world's third largest country. Now, two things are likely to happen, and because I'm an optimist, I'll emphasize the positive one, which is that Nigeria will probably leverage a larger stock of human resources to drive the imminent knowledge-based economy. Now, for this to happen, Nigeria must reprioritize her healthcare strategy and deepen investment in the healthcare sector. Of course, it's considered as the foundation of every human capital development. And there is a lot more going for Nigerians as in terms of, healthcare service delivery. Life expectancy is considered one of the lowest among 8 middle-income countries, ranging between 54 and 55 years for male and female. But despite many policy initiatives by succeeding health managers, Nigeria's health indicators are still not encouraging. We are ranked 187 out of 191 in terms of service delivery. Let's scale down. Maternal and child mortality rates, for instance, keep, oscillating, contributing 14% to global maternal mortality rate. Malaria is also said to be the leading cause of death among women and children. And in terms of budgeting, allocation to health dropped to 3.9% in 2018 from 4.23% in 2017 and 4.16% in 2016. Now, World Health Organization says Nigeria shares health resources health crisis with 57 other countries, identifies several factors, of course, interrelated. One is inadequate and unequitable distribution of healthcare providers like midwives, nurses, doctors, who are responsible for effective delivery of primary healthcare services at that level. Now, funding is also another very important to healthcare. Of course, this is the need to address high out-of-pocket healthcare funding in Nigeria. But here is the gist. Experts in health management and financing predict that Nigeria can't reverse these negative indicators, but only if there is a fundamental shift in the approach to issues of healthcare delivery and management. So, on Late Edition this week, we poke around the minds of experts in healthcare delivery for answers. I am Claire Adelabu Abdul Razak. Dr. Mustafa Zubairu Mahmoud is a public health specialist in immunization and primary health care space. Now, he was a leading effort that successfully held a recent consultative meeting of D8 member countries. Of course, it's aimed at integrating health and social protection in member countries' health plans. Dr. Mahmoud has since 2004 been providing leadership and managerial interventions in healthcare services. He was a supervising director, disease control and immunization at the National Primary Healthcare Development Agency. He pioneered and led the transformation of the immunization logistics system and championed the establishment of the Nigerian Immunization Technical Advisory Group. Now, between 2010 and 2014, Dr. Mahmood was Chief Medical Officer for Immunization. Of course, that paved the way for implementation and evaluation of new vaccines. We must have heard the pentavalent inactivated polio and, of course, the pneumococcal vaccines. You know, at the time it was trending. All right. His educational background: he has a bachelor degree in medicine at the Ahmadu Bello University in Zaria, and a master's degree in public health from the very prestigious University of Lagos. My second guest, Dr. Boluwatife, a very interesting name if you ask me, Lola Dari, is a community physician, epidemiologist, global health practitioner, and development expert. She is also passionately involved in the advocacy for gender rights issues, particularly women and girls. She's a data-savvy veteran with immense wealth of experience in application of evidence and data for policy. She's also an informed, innovative, and globally respected thought leader in health management and development matters. Dr. Boluwatife Lola Dari is currently the president, director, or rather the global director of a program called I Will Give Africa. That's IWG. I understand it's an innovative domestic resource mobilization platform, of course, to, in her own words, and I quote now, disrupt norms of development financing in Africa as, you know, Africa shifts from aid to trade. She's a graduate of College of Medicine. Of course, she attended the prestigious Holy Child College of Balinde in Lagos. She's also a student of, rather, she holds a Master's of Science degree in epidemiology with bias for statistics. All right, very robust resume. Dr. Mahmood and Dr. Lola Dari, thank you very much for joining me on Late Edition this week. I must confess, I was almost carried away by, you know, your resume, both of you, and of course your wealth of experience in the health, primary health service delivery. But let's start with, on a general note, the prediction I earlier talked about a population boom by the year 2050. In relation to healthcare delivery and management, what value does probably 440 million Nigerians, you know, bring to a country, you know, like ours? Let me start with Dr. Mahmood.
Thank you so much, and good evening, viewers. When you look at population, the narrative around population and health is a double-edged sword. Mm-hmm. If you are not prepared, then it brings you down. If you are very well prepared, you make the best use of it, and you get out there, and you'll be even recognized as a very good economic power to be reckoned with. Mm. Because there is no production without people. For you to produce, you need people. But for these people to produce very well, they need to be healthy. So if we get our health plans right, we implement our health strategies very well, just as we are trying to bring up this new body of DL to do, then it should not be much of a problem. It will be a very big problem if we stagnate the way we are right now. Because the way we are right now, the indices are still very poor. We've not gotten our acts together. We are fragmented. Even the policies and in implementation, we are still fragmented. Mm. And we're not even providing protection for the majority of the people that are poor, because you alluded to poverty there. Mm. So poverty is a very important thing to remove from that equation. If you don't remove that poverty, then nothing happens. And look at it this way: when you are sick, right, you don't work. When you don't work, what happens? You don't earn a living. Mm-hmm. When you don't earn a living, you become poor. When you are poor, you go hungry. When you go hungry, you go what? You become more sick. So it's a very vicious cycle. Mm. And I think one of the important things we actually want to do in this is bring in that social protection, remove poverty from that equation.
Mm. Okay, let me pause you for a while. Dr. Lola Dari, what is the weight that a large population such as that has been predicted for Nigeria, you know, has on a country's health, you know, care delivery system?
I think it was like Dr. Mahmoud has said, it's a double-edged sword. However, there's a huge potential in that demographic dividend. Because while many other populations are aging, Africa will have a vibrant young population.
Okay.
Which means that the emphasis on our healthcare system may need to shift from emphasis on just curative to preventing disease and keeping people healthy. And for young people, it means that we have to be concerned about a lot of things from the time a woman gets pregnant and make sure that our young people can survive, they can thrive, and they can excel. So we break up this development, this potential, not just into numbers, because all you hear is about the numbers, the 400 million, the 400 million, and how much is a disaster. Like people say, it's only a disaster when you don't plan. So I think this is the time to start planning on how to make sure that the healthcare system is not just focused on waiting for people to be ill, but is also focused on making sure that they remain healthy. Yeah. They are born healthy, they grow and are nurtured healthy, and that in their adolescent years, we support them to responsible adulthood. So from 0 to 6 is responsible parenting. From above 6, you have responsible education. And by the time a child is 18, he's already a responsible adult. Now, responsible adulthood is both a social issue and a health issue. You all know what adolescents are like. Sexual and reproductive health, ensuring they are aware of their bodies, they can negotiate their sexuality in ways that protects them. And in addition, that they are able to contribute to economic development in positive ways.
You talked about, you just mentioned the need for a shift in our strategy or in our system. And that brings to my mind the fact that we have at the moment the orthodox medicine, we have the alternative medicine, and we also have the traditional system of medicine. So what kind of system are we running? Do we have, because I know in Ghana they have an integrated healthcare system. Yes, let me bring in Dr. Mahmoud.
So our system is actually even more fragmented than what you have just painted. It's not just about orthodox medicine, traditional medicine, and the other. It's tiered. It's tiered. Federal takes control of certain activities, state do certain activities, local governments do certain activities, no synergy in between, no responsible coordination in between. And even within the health system itself, somebody is there, is focusing on malaria. Somebody is there, I speak malaria only, I understand malaria only, I do malaria only, and I do only polio. And it's only polio I know. Or I do family planning, or HIV/AIDS. This is the fragmented system, well, saying that it cannot hold. You need an integrated system where even the services are delivered. And just as Lola said, it's about the people, right? When you go to a supermarket and you can pick everything you want in one place, one shop, isn't it better for you? We need to shift towards that, where we have that kind of integrated health services. And it's like a supermarket. Whatever you want, you just pick and you move on.
Dr. Lala, what are the gaps that a fragmented healthcare system,
One of the major gaps is that you spend more money than you need. And in a resource country, in the place where we need to continue to grow our economic capacity, our health investment needs to be smarter. So if I have one person doing only polio, I'm actually not maximizing the capacity of that person, because that person can do much more than polio because he's in the hospital all day. But over and beyond that, the impact of fragmentation is that people have to go to too many bus stops before they get to their terminus. And that also is not only a waste of the human capital that the country has, it's also a waste of the resources that you have. Two, when you have a fragmented health system, and this is very popular in Nigeria, in most of African countries, where you have everybody wanting their health center next to them. Many more infrastructure don't produce health. Because if you have 10 hospitals instead of one, that means you need to pay 10 doctors, 10 nurses, 10 laboratory technologists, and you increase the cost of healthcare. But over and beyond that, our national health system is not only what is offered by the public sector or what is offered in the facility. Health occurs at home, health occurs everywhere you are. Your choices also affect your healthcare outcomes. So when the paradigm shift we need to make is not to think that health is a clinical matter that occurs only in a hospital. In fact, when you get to a hospital, you've already lost your healthcare. So we need to have that paradigm shift and say, when I'm planning for healthcare delivery to beautiful, wonderful Nigerians, I'm not planning only clinical care. I'm planning health promotion. I'm planning health education. I'm planning risk protection and risk screening for cancer, for pregnancies, for diabetes, for hypertension, so that you can remain healthy. So we come to healthcare planning in Nigeria and in most African countries at the moment from a clinical curative perspective alone. We don't take away from that importance, but we also know that we can prevent many more people from being ill by planning a system, by working on a system.
Is that a best practice?
Yes, like you just said, that includes, it's integrated not only by tiers, primary, secondary, and tertiary, including community and home-based care, but it's integrated horizontally. Traditional care, indigenous care, and all forms of alternate care, you can actually integrate into one-stop medicine, one-stop system. What we need to do is to have increasing dialogue on how best to offer that, and not only in a hospital.
Okay, well, I will get to the dialogue aspect of it. I know because both of you, were instrumental to the successful, hosting of a consultative meeting, where, of course, member countries, came, the D8 member countries shared experiences and best practices. But let's again dip a little further and get out some of the, issues in our health system. And I want to poke around your thinking, both of you now, on what you consider as major public health issues right at the moment in Nigeria. Dr. Mahmood.
Well, if you want to look at it, I think in a logical fashion, you say, where is my burden? And the majority of the burden is in the primary healthcare sector, because they are common diseases that afflict everybody. They are the ones that kill everybody. That's a big issue if you cannot tackle it. So in Nigeria, for example, if you cannot tackle malaria, you cannot tackle diarrhea, you cannot tackle pneumonia, then you are in big trouble. You cannot tackle measles, vaccine preventable diseases, you're already in big trouble.
You know why
So that's a big issue.
Yeah, sorry, you know why
And these are just basic health services.
You know why I asked this question? Because a lot of us, get confused when you read all the statistics and data coming from, international agencies and all that about, okay, hey, malaria is still the leading cause of, death, so in Nigeria. HIV is still very much high in Nigeria, and pneumonia is still the highest killer of childhood, So we get to hear, what is Nigeria even good at in terms of health delivery?
I think that we must respect and value the support of our international partners in terms of what they contribute to our health data, but we must first use our own data the way we want to use them, and I think that's a big gap. When you, like Dr. Mahmood has said, there are priority burdens that sometimes don't get into the international radar. So I would look at what are the priority problems that we have now in health. Nigeria is one country that has different ecosystems. So my priority in Lagos may be different from my priority in Maiduguri. Now the donors are very active in northern Nigeria, where we still need to address issues like old burdens, MDG burdens, old priorities. The unfinished business of the MDGs is still very vibrant in northern Nigeria. They are part of Nigeria, they are important, and we need to make sure that...
For the benefit of the doubt, can you give us some of the unfinished burdens?
The unfinished burden really relates to men, women and children. And that when immunization, making sure that every child is immunized, making sure that we reduce the scourge of maternal mortality in northern Nigeria is one of the highest in the world, making sure that people have access to basic services. But you couldn't say that for Lagos. Lagos is in an epidemiologic transition. And that transition means that although you still have these old unfinished MDG issues as endemic, they may not be their priority, but indeed they're not. So while Lagos may be vibrantly looking at mental health because of that epidemiological shift, Lagos may be looking at obesity because we look at things that relate to lifestyle. And so our health system is not a monolithic health system. So we need to make sure that we're looking at new emerging priorities of the non-communicable diseases that are driven by lifestyle and life choices. Thankfully, tobacco is not as vibrant in Nigeria
as it used to be.
As it used to be.
It used to be fashionable.
It used to be fashionable, and so we may not be dealing with that. As part of the NCDs, we need to look at cancers because our nutritional styles are the Food and Drug Administration, which is totally out of clinical care, impact on cancers, environment, climate change.
So does it mean if we address that area, we probably will be drawing down on prevalence of cancer cases? We
will be drawing down on some cancer causing factors. So air pollution. So so when my colleague sits in Abuja, they have the responsibility to reflect the diversity of our systems, the diversity of our priorities, and the diversity of our burdens to Nigeria. But importantly, we should look at what subnational governments are taking on board and responding to their people in a place like Ondo State, where they are largely agricultural. And indeed, in many parts of the country, chronic backache is a big issue there. Some people even tell you it's normal, that you can live with it, but it's not normal.
It's not normal.
You can actually address it.
It's not normal. Let me now scale down to specifics, and I'd like to bring Dr. Mahmoud here because he, of course, as I was reading his resume, I talked about the new vaccines which you provided leadership for, and I mean, cases like pneumonia, diphtheria, measles, meningitis, poliomyelitis, these are still trending, and the statistics I have, I don't know if it's anything to fall back on. It says 80% of 2.6 million deaths are traceable to some of these preventable diseases. And I'm wondering if we had that, new vaccine at the time, why are we still bedeviled? Why are we still burdened, by these diseases? Is it a case of ignorance or a case of reach?
So it's a factor of many things. One is the reach. We've not been able to reach every person that needs it. Coverage is still around 58, 60%. And with coverages in some places as low as 5% in the northern part of the country. I mean, this is really a huge problem. So you've brought in these new vaccines to protect the people. You've spent a lot of resources to get it out there and reach the people. You've not put in place the mechanisms to make sure that every child that needs to get these vaccines gets them. And I think the current efforts of government is in that direction to see how they strategize and say, oh, these are priority states or priority local governments. Let's pay more attention. And I'm sure the ED, the President Executive Director of the National Primary Healthcare Development Agency, has explained this before, that, okay, let's declare this as an emergency and tackle where this burden is heaviest, because no matter how much we do in Lagos and get everybody vaccinated in Lagos, right? Oh, and we have somebody in Sokoto at 5% or somebody in Yobe at 3% or something like that, then we still have a big problem.
Yes, because you can't stop the spillover other parts.
You just cannot.
Okay, you want to come in?
And in addition, we need to get our data systems right. Because sometimes when you examine the data and unpack it, just like we rebased GDP and found out that the Nigerian GDP, when we did it in a contemporary way, was much higher. I think that some of our indicators in health may be much higher than we actually report them. We use tools like the DHS. The DHS is a fantastic instrument, but we don't have state-level DHS. So DHS is a national sample. When I was working with the government in Ondo State, when we did a DHS Ondo and used the same style of the DHS, the reports we get from a sample of DHS, a valid sample in Ondo State, is higher than the national sample. Because the national sample is a nationally valid sample, may not be always valid as state. So I think we need to interface with that data. Two, we're not going to hit the targets that we need to hit if our health systems remain fragmented. and if service at a facility level remains fragmented. So we're spending a lot on healthcare, but we're not achieving what we need to achieve because of the state government and the federal government and the local government and private sector and civil society have not come together to align their resources, align data. So we're missing out a lot, yet spending a lot of money. So invest.
When you say spend a lot of money, now that takes my mind to federal allocation, which has, well, both of you know the data. I don't have the data. When compared to what other countries are spending, would you consider that as much? Or the much? I don't know the much.
Can I please differ?
Go ahead.
Can I please differ? When I read financing statistics for Nigeria and I hear federal allocation, Nigerians don't access healthcare from federal budgets alone. There are state budgets. There are local government budgets. There are private sector budgets. And I'm not sure we have a system that has actually pooled all of those resources together. You've mentioned, when you mentioned healthcare financing, healthcare financing in no country can be supported fully from public resources. There are so many resources that come into private, and we have people like Dangote. Thank you, Aliko Dangote, for what you do in investing in health. There are Bill Gates Foundation. They're giving us loads of money in health. Access Act Foundation. Those are also philanthropic resources in health that are emerging. Sahara Foundation. So I can go and mention so many. So when we focus on the sole investment of federal allocation, and it's not as if federal government has taken health out of every allocation to a state level and pulled it.
Okay.
It may not be a true reflection of the percentage spending of the total expenditure in Nigeria on health.
Yes.
Be that as it may, we need to spend more, but we need to spend smarter. More is not always better.
Okay, I think
let me just also add that we have a national health account system that actually tries to pull everything together.
Yes.
And then when you look at when these things are still pulled together, actually we have still not spent what we ought to spend. The total health expenditure is just about 10% of what the entire budget of the country is. So it's not there. And when you compare it to the GDP, it's less than 1%. It's less than 1%. When many other countries are spending in the range of 3%, 4.5%, 5% of their entire GDP on health. At this meeting, Bangladesh was spending 3% of their entire GDP on health.
But there are countries.
Let's also balance it. Yes, we're doing better. We're getting there, but we're not yet there. We're still far away from others that are in the same category with us. And I think our leaders need to know this correctly. So if we were running at 20 kilometers per hour before, my God, we need to double, I don't know, triple the speed, I don't know. Maybe run at 160 kilometers to be able to catch them.
Dr. Loladare,
I agree with it.
Come out with it.
I agree we need to invest more in health. But if I had the opportunity, I will make sure that we address efficiency of our spending first. Because good health can occur at low cost. Nigeria spends $120 per capita on health, and it does not achieve the outcomes of people who spend $40 per capita. Why? Is it money? No. Efficiency. It's efficiency. So putting more money into necessarily a leaking basket may not be a smart idea. So as we put water in, the first thing is to turn our basket into a bucket that can retain the water, rather than continue to put money into a leaking basket. So we need to look at more, but we need to look at smart, and we need to look at efficient, so that the money can achieve what it's meant to achieve. So yes, we need to run, but we appear to be pulling our race in different directions.
Fragmentation again.
Another fragmentation.
Dr. Boluwatife, Loladare, and Dr. Mahmood, I'll just pause you for a while. We'll take a short break. Of course, we're looking at innovative approach to healthcare delivery in Nigeria. And this is against the background of the D8 consultative meeting, which held recently here in Abuja, Nigeria. We'll be right back. This is Late Edition. is Late Edition. My guest, Dr. Mustapha Zubairu Mahmood, and of course, Dr. Boluwatife Lola Dare. Once again, I'd like to appreciate you for joining me on the program. Let me start with you this time around, Dr. Lola Dare, and it's all about women and children. I know this is an area for which you've shown great passion and advocacy. 14% that Nigeria contributes to global maternal mortality. Why should any woman die from childbirth?
I think you've asked me the wrong question. No woman should die from childbirth. No woman should die giving life to another person. So the question is, what shall we do? Our maternal mortality rate in Nigeria is very skewed. It's not the same in every part of the country. So some parts of the country seem to have got it right, and some parts of the country need to do better. So I think first is to learn within Nigeria what's happening in the parts of the country where it's even in parts of the country where it's low, it's still unacceptably high. So early access to healthcare services is one of the biggest things that help a woman deliver safely. From the time of conception, even from the time of preconception, when we think that and I think that practice is dying down, when we practice genital mutilation, when we don't give women the education they need, and boys are favored over the education, we know that education helps you to make the right health choices. So I think we're addressing that in some parts of the country, but education, female genital mutilation, and nutrition for the girl child are important preconditions for having a safe delivery. Then the young lady gets pregnant. We have to make sure that we address early pregnancy at a young age when the girl is not ready, or the services to support her to have safe delivery do not exist. Then when the woman is pregnant, there are certain preventive efforts that need to be in place. The woman has to have access to antenatal care. The woman has to have access to tetanus toxoid, so that they can identify high-risk pregnancies that should not be delivered at home, but should be delivered under attentive care. So the biggest things that we need to do is to make sure that women have access to the services they need across a life continuum, from the day they are born to the time they reach the reproductive age and thereafter. And I think that there are some efforts to address that at the moment.
Dr. Mahmood, if you want to stay put on this, you should be able to.
Things also. I think individual households also, in relation to our mothers, our daughters, our sisters and aunties, need to make the right decision at the right time when a woman is pregnant, so as to avoid all the delays that can happen from accessing services. I mean, if you are a husband and you need to give permission to your wife, give her a very flexible permission so that she can access her services at any point in time. Because labor does not announce itself, even though doctors have gone a little step and say, oh, okay, we know your expected date of delivery.
The EDDs.
But it does not announce itself. You are women anyway, you will tell me whether it announces itself. Then second thing again, we have to also improve on that social infrastructure, because if I'm in a remote village, 90 miles away, or like my place, about 40 kilometers away actually from the next major city, and then it happens to me 2 a.m. in the night, and the infrastructure to deliver this is not there. The roads are not there. The vehicles to pick me there is not there. The system to make this work and take me to where I can get services is not there. I think that's also a problem. And then if you have some cultural issues that are affecting certain things, and people say, oh no, I don't want to deliver in hospital. I had all my 3 children safely at home and all the rest. Grandmothers delivered us under the tree or under the shade. No, I think such cultural things also should also, government actually has to do a lot and address these things all encompassing.
But there are some measures.
I know finances are also key.
Yes, she talked about success. Yes. I just would like both of you to also speak to the issue of the social protection aspect, because this is also part of what the D8, is about. And I know that the present administration has tried to expand, the reach for its social protection programs like the SIP, the conditional cash transfer, which is premised on the condition that a woman access one or many areas of need. Health is inclusive. What value do you think that would also add in bridging the gap in maternal and infant mortality? Okay, Dr. Bolatife wants to say something.
Social protection targets the poor, and it also helps them to be able to not only access conditional cash transfers if they can't afford it, but social protection programs is also entrepreneurial, building their entrepreneurial capacity so that they have sustainable livelihood.
Yeah, precisely.
One of the programs we support under social protection is an effort that goes from 0 to 60 months for mother-child pairs.
Okay.
So that as they are able to access service, mother is also able to earn. Okay. Because if you look at our total fertility rate, some women have children under 5, 3, 4, yes. Yeah. And they're all under 5. They're all under 60 months. The capacity of that woman to earn is already compromised because she needs to look after 4 children under 60 months. So
skills training is key, it's critical.
Skills training is critical. That it helps that woman earn and helps her to be, because if you don't have, one of the big reasons why we wait for our dear husbands is that darling is going to pay for the services.
It doesn't come easy these days.
It doesn't come easy these days for both him and his wife. So because he's going to pay for the services and the woman does not have enough to even take a Maura to the health center, she has to wait for her husband. And that's it is said that 80% of women wait because the breadwinner who is going to pay for the services, transportation, is not around. And so building sustainable livelihood through social protection systems that provide SMEs for women is part of healthcare.
But some of your member countries, Nigeria now, because we're zeroing on Nigeria, is already doing this. So why are we not getting the desired outcome?
Is there early days yet for the social protection for Dr. Mahmood?
Well, you see, these things take a long time to get the desired result, to make the impact. And then it's a question of numbers. When you are looking at the very poor people in Nigeria, we're talking about millions and millions. I guess one of the figures I have is about 70 million Nigerians are poor, right? And if over 70 million Nigerians are poor, and you're doing a social investment program that has not had that far reach of, let's say we've covered 20 million Nigerians, for example, will you be able to demonstrate any impact reasonably? The answer is no. But you need to do it in such a way that I think, from my own perspective, should be done in such a way that it is additive. One strategy is additive on the other and creates a kind of multiplier effect. You alluded to the conditional cash transfer. The conditional cash transfer should be done in such a way, and I think they are doing that, that it becomes like a stimulant for positive behavior, because there are so many things you can do on your own individual basis to be healthy. Hygiene is one of the simplest things that you can practice on your own just to be healthy. Clean your surroundings, your personal self, etc. So I think we need to do that and reinforce such things. Not just a question of reinforcing, okay, you get the conditional cash transfer, it covers your transport, etc. No, I think the conditional cash transfer should go beyond that. It's not just about because you've eliminated the transport need for the woman, but also to encourage her to put that child to go to school.
Early learning.
Early learning. It's also to make sure that child accesses immunization services, and she makes that deliberate effort to take the child for immunization, growth monitoring. There are so many things you can do under that ambit. I think this is the kind of strategies I think we need to put in place actually to make it work. But what she has said, we have a very young population, and I think the SMEs are very relevant in this arena, because they are the largest creators of jobs everywhere. And I think we need to actually go one step forward and identify, even if they are crafts entrepreneurs, right? They can still make some money, and government must support them very well. I see no reason why, for example, we are all here in Nigeria, we cannot be supporting the mechanics and then giving them the facilities so that they can actually grow and become bigger workshops and bigger things. Or we cannot do many other things. Our young guys are very intelligent, very brilliant, taking to social media.
I understand that the central bank is disbursing some soft loans to youth corps members. I mean, you know, of course, well, that should go a long way. But let's hear from you, Dr.
Part of what this is what I said about Nigeria having many islands of hope. There are so many islands of hope. What government should do is work towards coalescing the islands of hope.
Okay.
So I may have conditional transfer here, but not have SME here. I have access to services here, but I don't have a complete package in each location. So I have a hope on services here, but that same hope is not linked to the hope of sustainable livelihood. Or I have a hope of immunization here, and it's not linked to a strengthened healthcare system. Dr. Ado started our discussion with saying we are fragmented. So that fragmentation is a key thing. Now, whatever we do, we must not forget that it's happening in an environment where we need to pay attention to our economic indices. There is an interaction between survival, economic growth, and social protection. If we create 20 million or more SMEs, and we don't address the macroeconomic environment within which they would express themselves, we would also may not maximize the investment in that process. So I think we need to look at how we make health in every sector and every sector in health, so that we have a more integrated approach, and we need to track data. One of the things that the SIP may need to do much better is report and track data. And I hear that there is investment now to build a reporting and data system that tracks the impact of what we are doing. So we are counting numbers and saying we've given 20 million, we've given 50 million, but we are not saying how much it has changed the lives of 50 million and how it is impacting on our social protection systems and economic indicators.
Okay, let's zero down now, because we're winding down on D8, the inaugural consultative meeting we just held. D8 is a group of, you know, countries, middle-income countries, based on their GDP standing, you know, that have, you know, pledged to commit the resources together to, of course, develop certain aspects, critical aspects in their development plan. Tell us, what is this all about in a nutshell?
So, in a nutshell, I would say these 8 countries of Nigeria, Turkey, Malaysia, Pakistan, Bangladesh, Iran, and I think I've mentioned all of them. Egypt. As you have said, have the same experience in terms of where they were before and where they're going. They also do have, some of them are growing rapidly now, so their growth rates are like very good. Some have reached that level, so it's actually a mixed bag now. So we believe that within this group, since you have this mixed bag of very good and not so good, then the very good can help and lift the not so good. And if we are in that bag, I think we stand a lot to gain by forging solidarity amongst ourselves, forging cooperation, coming up with innovative ways of doing things, and exploring other avenues of the resources, the much needed resources that we're all craving for, right? And how to even use them efficiently. Because, and that's the whole essence of the D8 thing.
This gain, in what form is it likely to come? In the form of financial assistance, in the form of technical support? Dr. Loladare?
The D8 Social Protection Program first allows countries to not be fragmented. And so they are organized around 7 pillars of work: essential health services and system support, non-communicable diseases, health governance, social protection, unlocking the market potential of the health in the health sector, innovative financing, and data. This allows us to have a focus rather than fragment across 8 countries where architecture for health systems are different, like Dr. Mahmoud has said, and health burdens are different. So the first benefit, which cannot be quantified in financial terms, is the benefit of learning and sharing and quick adaptation of what you know is working somewhere among 8 focused countries. Okay. That's a great benefit. The second benefit lies in that second pillar. Is it the fourth or fifth pillar? That is the one that is unlocking market potential. Within those eight countries, they represent 13% of the world's population. They represent over 1 billion people. That's a huge block of people that's working together and in the spirit of the SDG, building partnerships to unlock a market potential. Unlocking the private sector potential and market potential means they release more money to available for health. But for me, of the seven, for many of us, and across all the countries, no matter where you think you are, how good you think you've performed, everybody needs more money. It's very clear that public financing must lead, but public financing alone is not going to finance the kind of healthcare system we need to have. So one of the biggest advantages they have is that they're now focusing on needs-based financing, looking at what they need and pulling all resources in country and across their countries to support that. Where would these resources come from?
How much is this group? How much is it worth? I'd like you to take that as well as look at a major issue which was raised, and that was how I think one of the countries raised that, and which is the issue it raised was, I mean, it's also resonates with Nigeria as well. That's the issue of how will I say, low level capacity in the rural areas. How do you sustain? Because we know when you deploy your healthcare providers in the rural areas, nurses, doctors, you hardly find them. They hardly stay. So sustaining them there becomes a problem. I think one of the countries raised that, and it's also it's something that it's also common here. So what are the outcome? How from this meeting on how to address that?
So you have so many questions in one. Is this group worth anything?
It's just one question.
It's just one question. Everything, because this group, the bucket size of this group alone is more than Europe.
Yes.
Is more than Europe.
It's a big
so if we get our acts together, we are more than Europe. We actually made projections that if we go on these pillars, our GDP will rise to about $2.7 trillion.
That's Nigeria's GDP?
No, the entire collective GDP. Collective GDP. And then the average life expectancy will also rise by at least 4 years. So this group, I think, is worth everything.
How are they going to pull Nigeria?
For Nigeria, for Nigeria, this is how it's going to work. You're going to get some foreign direct investments coming into the country because some of these are already higher on the curve and they are keen in helping. It's a solidarity forum, right? And we are enabling solidarity amongst each other. And what it therefore means is that we're going to learn those beautiful things in addition to getting those foreign direct investments. And then coming to the other question you were asking, I think, even from this meeting alone, we've learned a lot. Imagine Bangladesh was far behind, right? They came up with community clinics. They established 13,000 community clinics. We have done that. The issues you alluded to in terms of how do you get the staff to man these places, their rural areas, their etc. Simple thing they did. Their prime minister, their leaders were committed to that and say, look, communities give us land. That's all we require from you. We'll provide the building. And they were not going for high-story buildings. They were going for 2-3 bedrooms, right? Or 2-3 rooms. I say bedroom, sorry, my language. 2-3 rooms. And ask the community and say, bring 2 or 3 health workers or people that will train. And they gave them training for only 3 to 4 months and left them in their communities.
This is Bangladesh.
That's Bangladesh. And ask the representative of the people to pioneer this there and make sure it works and put up a management structure and say, we have provided this equipment, everything, you take charge, run it. But they didn't do that alone. They legislated it.
No,
the meaning of that legislation was to prevent abuse because we know our systems. Nepotism creeps in easily, right? You are the representative of the people. It's only my sisters, it's only my brothers that will go into this business. So they legislated it and make sure that even if you come after me, you can just wish it away.
That brings
now from 5%, they are already at 55% universal health coverage. And they want to add
well,
another
whatever that
16,000 more.
means. Whatever that means. I was going to take that next question because I remember you said that also. Well, please go ahead with your...
Yes, whatever, universal health coverage is the latest kid in the town. Important as it is, but it means different things in different contexts. And so when we are comparing what people have achieved, we need to make sure we're not comparing apples and oranges. But you asked the question, how are these countries going to help Nigeria? Can Nigeria please help itself? It's time for Nigerians to also know that we're not going to... One of the best things I like about what the D8 group is doing is changing development paradigms, changing it from dependence to self-reliance. And so if Nigeria should also position itself to make the best of that opportunity that the D8 is providing to us, to learn from countries similar to us, to be part of a bloc that can take positions within global health that will help us build on what we already have. Yes, we are doing a lot, but I think we should have an internal discussion on how we ourselves are able to contribute to that process and not just be beneficiaries of that process and learn from that process. So I would like to appeal to Nigerians who are active in the health sector and to our leaders to say we must continually ask ourselves, how can we better position ourselves? How can we better help ourselves? That is the paradigm shift that the D8 represents to us, that we can do it with like-minded progressive countries who are similar to us and they're low and middle income countries, and that we have to take the responsibility to stop our financing for health being a begging bowl process to a cooking pot process.
Okay, Nigeria is a member of these D8 countries. So, Dr. Mahmoud, this is the last question I have for you. Going forward now, what is Nigeria likely to leverage, and how is it going to change things, the way we run the health system?
So the way we structure the meeting is that immediately after the meeting, there will be a few things that each country will do, and all of us agree that we will do. And I think we will start that way by deepening political engagement within the country, just as she has alluded to. Sit yourselves down, talk. Is there a way you can do these things in a more sustainable,
We've been
reliable
talking,
way?
Dr. Mahmoud. We've been talking.
But now we're going with a commitment, some agreement.
Binding?
Well, you won't say binding for now, but in the spirit of solidarity, I think it's worth trying. But Lola, you want to help?
No, one of the key things, I am civil society, and he playfully calls me an activist. And one of the beautiful things that the D8 Secretariat has done is to bring in amplifiers. People like organizations such as mine, organizations such as WAVA. We are amplifiers. And I think that the binding way is to amplify the messages of the D8 social protection within Nigeria, within global health, and make sure that the message is getting to the people. We need to get the message to the people. We need to get the message to policymakers.
In less than 30 seconds, what's the message?
The message is we should go from begging bowls to cooking pots. And we should finance our healthcare from domestic resources that are aligned with those of our regional neighbors.
Dr. Mahmoud?
And we should also make sure that whatever we are investing in health, we're investing it efficiently, so that this wealth creates actually health.
Dr. Mustafa Zubairu Mahmoud, of course, a public health specialist, and one of the, he provided a very robust leadership in the just concluded inaugural consultative meeting of the 8 member countries. Thank you very much for joining me. Dr. Boluwatife, of course, who is the president of Chestrad Global, which is a non-governmental?
It's a social enterprise. It's a global social enterprise.
Okay, of course, with a very, very strong passion for women and, girl gender issues in health. I'd like to thank both of you for joining me on Late Edition this week.
Thank you for having us.
All right, that's the way it's been, looking at innovative approach to solving our health problems this week on Late Edition. Thank you for watching. On behalf of the production crew, I am Claire Adilabo Abdulrazak. Bye-bye.